Thanks again for the nice introduction, and sorry for the long title. So I think this is some kind of a... Yeah, maybe next time I use 2 slides, yeah, to use it for one title. So these are my disclosures. And so just a reminder for you, so that we had in the last few years already presented our data on, presented our data on HIV amplification and sequencing strategies, and at that time already focusing on whole genome sequencing. And you can, sure, of course, do this either by using just one fragment, so one amplicon, or overlapping amplicons. And of course, what you can do is, in the case of you using one amplicon, you should use definitely a long-range sequencing strategy, which maybe can be the Oxford nanopore. So at that time, we have also focused already on APOBEC mutations. So we are looking here only on proviral DNA. And so here you see the distribution of APOBEC induced stop codons, which we used for, and this is for Jonathan, as a replication incompetence marker. Yeah, this is what we did. And sure, what we will do in the end is just to make a covariation analysis where we see whether there are stop codons on the same strands than drug resistance mutations. So you can make it a bit more complicated with the next slide. So what we see is just a separation of the APOBEC population. So in this case, a 203.30I mutation together with stop codons, and would like to separate these from the more, in this case, dangerous replicative active drug resistance populations, in this case in the integrase 138K and 155A mutation without any stops within that. So this was the point where we decided to go for a proof of concept study, in which were 70 highly treatment experienced patients included. We did the DNA extraction directly from purified PBMCs. We just applied a single PCR, not a nested PCR, a single PCR, which is near full length, and that in a triplicate approach to get as much variance as possible. So these samples were sequenced in a hybrid sequence approach with a parallel ONT and Illumina, and the Illumina approach was done much more for accuracy compared to the ONT approach. The bioinformatics used the in-house pipeline with the covariation analysis, and this was, as I've shown already, for visualization. So we were only focusing on near full-length genomes. You know, there are a lot of smaller genomes, so you will get some letter in your gel, a lot of defective variants with deletions. And so we were only focusing on the almost near full-length genomes. And of course, the criteria for the separation for the replication incompetence of individual variants was defined as the presence of premature stop codons found anywhere in the genome. So this is a short overview on the patients included. And there it is, and you see patients were first diagnosed, so in the late 80s as well, and duration of ARDS, up to 30 years. Most of the patients were under the limit of detection, less than 40 degrees, just 2 of these with a low-level replication, or it was a blip. And you see at the current ARDS that a lot of those patients had already several regimes, and so these are typical, most of them for a salvage situation. Yeah, so this was the first result, and this was not very surprising, in which it says that the prediction of putative replication incompetence and this by covariation analysis on sequencing from short technology is less effective than when using long reads. So this is not very surprising and plausible, I think, to almost everybody, because these are short reads, and finding always on the same read stop codon, this is not always given. So these are the overall results, what we found from these 17 patients. So there were 9 patients here which had a mixture of different variants, so APOBEC and purely resistant variants. 1 patient had only APOBEC, and 7 of these had no APOBEC mutations at all. And in the graph on the right side, in graph B, you see here we are focusing on APOBEC missense mutations, so not the stop codon, so missense mutation, which are on the same strand than APOBEC-induced stop codon. And you see, if this is the measure for replication incompetence, you see that all of these are at the bottom and, yeah, virtually replication incompetent. On the other side, the non-APOBEC resistance, so true resistance mutation, there were still a few mutations for all the patients, which were still classified as replication competent. So focusing on these 9 patients having mixtures, and you'll see that is varying from just a few percent left here at the bottom. Doesn't work really good. So right here, a few percent of replication competent variants still left, but up to, yeah, sometimes just a few APOBEC stop codons or APOBEC populations. So I would like to focus at least at 1 patient. So this is patient 19. I would like to go a bit more into detail. And this patient was already infected for a long time, since 1995, and is right now on 3TC, doravirine, and dolutegravir. And this is what we found here, is that if you put all these mutations together, irrespective where they are coming from, so there were integrase mutations already. There's one G118S, which is not the typical resistance mutation right there, but maybe indicate that there is something going on. There are some NNRTI mutations, typically and at the position 230, G190R, as well here down at the position E138 as well, and K103N. So all in all, you may interpret this as that the patient is with his treatment right now at the cutting edge of a sufficient treatment. But if you look at here, so all of these here, and you see total frequency and those variants which are defect here, and you see that this is completely the same. All of these here upstairs, the APOBEC missense mutations, are replicative inactive, and here is just a rest of those which may be replicative competent. So I would like to conclude this already. So this is just by using near full-length amplification of the HIV genome in combination with a long-read sequencing approach, we were able to discriminate the APOBEC from potential replication competent populations in the proviral DNA. And maybe, but could be, contribute to the clarification why some patients may respond to a so-called ineffective therapy. But of course, there's no light without shadow. So I would like to have formulate a question: how representative are we really when we are looking for the proviral population, for the proviral archive? As there were a lot of publications showing that it was reproducible Yeah, so looking at the resistance mutations in a follow-up 1 year later, but there were also those which were never successful in refinding mutations once found. So this is what I would like to end with. Thank you so much.